Acid-base disorders today. I figure you guys know the simple ones. So there's some clues to find if you have a mixed disorder. First, that the numbers don't follow the acid-base rules. So I just wrote them down here for you so that you remember them all again. Metabolic acidosis is 1-to-1. The PCO2, these are all PCO2 versus bicarbonate. Change 1-to-1 in metabolic acidosis. In metabolic acidosis, the PCO2 change is 0.7 for every 1 change in the bicarbonate as a compensation. In respiratory acidosis, you divide the respiratory acid-base disorders into acute and chronic. In acute, the bicarbonate goes up 1.5 for every increase of 10 of the PCO2. And chronically, it goes up 3.3 for every 10 increase in the PCO2. In respiratory alkalosis, again, it's 1.5. Now it's the other direction. Bicarb falls for every 10 fall on the PCO2. And chronically, the bicarbonate falls 5 for every 10 fall on the PCO2. So you have to know these rules when you look at your patient in order to know that it doesn't follow one of the rules. If you don't know these rules, you won't know that you're not following the rule and you'll miss mixed acid-base disorders. So you have to know all these compensatory rules, not just the metabolic acidosis, one that everybody remembers. So the question when you see the numbers is, do the numbers fit one of these simple rules? And if it doesn't, then you're dealing with a mixed acid-base disorder. Another clue that you have a mixed acid-base disorder is you have normal numbers. So the PCO2, pH, and bicarbonate are normal, but clinically it looks like there should be acid-base disorders. So for instance, if you have someone with ketoacidosis who's vomiting, and you're sure the ketoacidosis is severe, they should have a metabolic acidosis. So if the numbers come back normal or close to normal, and yet clinically you have things that should be causing acid-base disorders, you have to hypothesize that there's a mixed disorder. And that's why the numbers are coming back close to normal or normal. The other clue is we use this thing called the delta anion gap or the delta-delta, which I'll talk about here. But if the delta anion gap with the plus the current bicarbonate is greater than normal, it suggests that you have a mixed acid-base disorder present. Because if it came back to normal, then that would be just a simple metabolic acidosis. But if it comes back to a number greater than normal, it suggests you must have a mixed disorder. So just the concept of the delta anion gap, it's overly simplified. The thought is that you have a proton coming in with anions into the body, and in the steady state, the protons will be excreted and the anions will be excreted. And if these two inputs and outputs are equal, and also if they go into the same volume, which is a big assumption, then the drop in the bicarbonate that occurs from the proton input and output will equal the elevation in the anion gap. But the assumption is that they're both going into the same volume and that their rates of their inputs are equal because they're coming in as the acid, lactic acid or ketoacids. But the assumption is that the outputs from the body are also equal and that they're going into the same volume of distribution. And it turns out that that's not true. The volume of distribution of a proton is much greater than most anions. And so just from that alone, you would never, even if you had no excretion in someone with ESRD, and you put lactic acid into the body or ketones, beta-hydroxybutyrate or acetoacetate with a proton, you would never think that the changes would be equal because the proton goes into a much bigger volume of distribution. And so just that thought alone would make you not want to even analyze this. The other thing is that the anions are not excreted equally. For instance, lactate is not excreted well because it's absorbed by the sodium lactate co-transporter in the proximal tubules. So in fact, when in lactic acidosis, you tend to see a ratio of 1.6 to 1, where the lactate anion has gone up much more than the bicarbonate fell, just because the lactate isn't excreted well. Whereas with ketone bodies, you tend to see more 1 to 1. But in general, you would never expect to see 1 to 1, just because of the volumes of distributions being so unequal. So this whole idea of the delta-delta gap is sort of a nice thought experiment, but in the real world, it's not something that's quantitatively perfect that you'd want to used to analyze acid-base disorders with certitude. However, if you do it and it comes back that the bicarbonate is greater than normal, it suggests you have another process in addition to the metabolic acidosis that's raising the bicarbonate. It could be a metabolic alkalosis, it could be respiratory acidosis, but something is raising the bicarbonate so that your number is greater than 25. And then the fourth clue that you have a mixed disorder is if you have metabolic acid-base disorders, whether it's metabolic acidosis or alkalosis, but the compensation isn't what it should be. So remember, the metabolic acid-base disorders have these compensatory rules. And the thought is that if it's not that, then by definition, you don't just write on the chart it's not compensated. By definition, you must have a respiratory acid-base disorder. So the lack of an appropriate compensation means that you must have a mixed disorder. So these are the four clues. Now just some other technical things. Remember to distinguish the word bicarbonate from total CO2. What we get back from the chem panel is the total CO2. It's not just bicarbonate. It measures bicarbonate plus dissolved carbon dioxide plus carbonic acid plus carbonate. And these things are small. They're in the micromolar range, so you can clinically forget it. But the dissolved carbon dioxide concentration is around 1.2 millimolar. It's 0.03 times whatever your PCO2 is. So as the PCO2 goes up, that's going to raise the total CO2 on the chem panel, independent of what the bicarbonate is. So you just have to keep that in mind. People with a marked respiratory acidosis can have a total CO2 on the chem panel come back higher than you would expect from the bicarbonate that comes as a calculated number that you get back from your blood gases. Remember also that male numbers are greater than female numbers. Females don't have PCO2s of 40. It's usually 37 and 36. And their bicarbs aren't 25. It's usually 23, 22. Remember also the venous arterial differences. You tend to get venous gases. Remember that the PCO2 is typically 43. It's 3 higher than the arterial. And the bicarbonate is 1 less than the arterial. And the pH is 0.03 less. So the pH would be 7.37 for a pH of 7.4 in the blood. So just remember those technical things. Looking for an eraser here.
Oh my God.
I'm not gonna-
There's some napkins. That'll probably work. Yeah.
Okay, so with that, let's go to the first patient. So this is a 20-year-old male who was chronically vomiting. And had these numbers. Diabetic. Mild dysnatremia, hypokalemia, a little bit of pre-renal failure, and normal blood gases. So what's going on?
There's like disorder.
Right. So
Metabolic alkalosis.
why do you say that?
Well, honestly, even if I didn't see the numbers, I would say clinically he'd have a metabolic alkalosis.
From the vomiting, right?
Oh yeah, I used to climb up.
Okay, but what is the clinical clue that there's a metabolic acidosis here?
Yeah, there's a gap.
Now, what is it?
20?
20. So remember, anions, when they come into the body, always come in with a proton. They don't come in with sodium or potassium. And because they come in with a proton, the substance creates a metabolic acidosis. Remember, the anion does not cause the metabolic acidosis. It's just a clue that you had a proton load. So the fact that the anion gap's increased means you must have had a proton load, and yet the bicarbonate is 25. So that tells you there must be something increasing it. So what's increasing it doesn't have to be metabolic alkalosis. It could be respiratory acidosis. You always have to think of that. It's just that if it was respiratory acidosis, you tend not to have the PCO2 return to normal as a compensation from the metabolic acidosis, usually because the respiratory acidosis has a more chronic reason for not ventilating normally. But you theoretically could have someone with a chronic respiratory acidosis who then got a metabolic acidosis, and the numbers come out completely normal, if the ventilatory problem was reversible. Okay, but clinically you tend not to see that. That's why it's the elevation of the bicarbonate tends to be more commonly metabolic alkalosis. But remember, it could be chronic respiratory acidosis or acute respiratory acidosis if it was severe enough. Okay, so this is and what's the metabolic acidosis likely due to?
Could be ketones.
Yeah, it's most likely keto acids.
Oh yeah, it's a diabetic.
Yeah.
Yeah, so this is most likely diabetic ketoacidosis in someone who's been vomiting. Now, can you have ketoacidosis without the elevation of the anion gap?
Yes.
Yes, why is that?
If you deplete.
Right. So if you have the anion, coming in with the proton, but the anions are leaving as quickly as they're coming in, the anion gap will never increase. And in ketoacidosis, what determines the anion excretion rate?
Renal
Renal function.
Yeah, the GFR.
Zero fluids.
So as your GFR goes down, your anion gap goes up in ketoacidosis. So someone who's spontaneously euvolemic, or someone who was not euvolemic but was treated, their anion gaps will fall. And it's not because the ketoacidosis is getting better, it's just that they're excreting it. And so you have to look for the ketone bodies in the urine in these people. It won't be in the blood, but don't think that the ketoacidosis is improving. Okay, let's do another patient. This is a 35-year-old male, HIV positive, who got Bactrim for pneumocystis. So this was a year ago. These are the new numbers here. So what's the acid-base diagnosis?
Anion Gap, Metabolic Acidosis.
Okay.
And I think he's compensating too well.
What do you think about the compensation?
I'm about to do math, but just on the base of it, I would say it's probably too good, so it's probably
It's
got a
too good.
respiratory alkalosis.
Yeah, you're right.
Yeah, what should the PCO2 be?
7 for every.
1 to 1, so it would be 10 down, or 9 down, it should be 31.
Should be at 30, 31. So 30, 31 becomes your new norm. And everything above that is respiratory acidosis. And everything below that is respiratory alkalosis.
Yeah.
So that confuses people. They go, well, if it was 33, 34, how could that be respiratory acidosis? It's below 40. But the point is, when you have a metabolic acidosis or alkalosis, you define what the PCO2 should be, and that's your new norm. And everything above that then is respiratory acidosis, and everything below that is respiratory alkalosis. So the PCO2 should be 30, 31 here, so 25 is below it. So he's ventilating more than you would predict, so he has a respiratory alkalosis in addition. And what's his metabolic acidosis due to here? What's going on?
Anaerobic corticosteroids.
Well, he's on Bactrim. What does that do?
Did you mention RTA?
Right. So Bactrim,
He's also got renal failure.
and he's got some renal failure too. So Bactrim, remember, blocks, this is the principal cell in the portal collecting duct. So the picture is that you have the ENaC sodium channel here, and then on the apical membrane is the ROM-K potassium channel. And sodium comes in here, and potassium comes out. And potassium here sees this apical membrane voltage, which is usually 20 to 30 millivolts more negative inside than outside. But when sodium comes in, it depolarizes this voltage, it makes it less negative. And that allows potassium to come out more easily. So the more sodium coming in here, the less this voltage difference is. And then K can come out here down the concentration gradient. The potassium in the cell is 100. And in the lumen it's 15 to 20. So there's a chemical gradient for K to leave, but it's opposed by this electrical gradient. So that's why sodium absorption here is so important for K secretion. If you block this channel, you make this voltage much more negative. So instead of minus 20, minus 30, it can go to minus 50 or minus 60. And that prevents the K from leaving. That's what amiloride does, or pentamidine, which is in the Bactrim. So this person has a type 4 RTA because the ENaC sodium channel was blocked by Bactrim, and so K can't come out. Remember that all the potassium in your urine is potassium that was secreted by this cell. All the potassium that comes through the glomerulus is absorbed in the thick ascending limb and the proximal tubule. There's no potassium left. All the K in your urine is secreted from principal cells in the cortical collecting duct. So it's responsible for the TTKG, it's responsible for changes in the fractional excretion of potassium or the absolute potassium excretion. When you're looking at potassium in the urine, it's basically a function test for the principal cells in the cortical collecting duct as to what they're doing. This is another patient, 33-year-old female with congestive heart failure. And in the hospital, she got more short of breath, and then these are the second set of numbers. what do you think's going on here?
She's Eucapnic.
Yeah, she's short of breath. This is the PCO2 67, bicarbonate's 37. She was on Lasix chronically.
Yeah.
These are her numbers normally. So normally these are her numbers. And her PCO2 went to 67 in the bicarbonate. So what is she doing? What is normally? What has she got?
Metabolic Alkalosis.
Yeah, compensated metabolic
Yeah.
alkalosis. Right? Bicarbonate has gone up about 11. In a female, it starts at 33. This has gone up about 0.7 of that. So it's just what you'd expect for the compensation for the PCO2 to go from 37, 38 up to 47. Might be a bit higher for a female than you'd expect. And then she got shortness of breath and something else happened here. So what does she have here in addition to the metabolic alkalosis?
Respiratory Acidosis.
Right, what kind, acute or chronic?
Acute.
Right, because for every 10 increase in the PCO2, the bicarb goes up 1.5 roughly. So you can see the PCO2 went up by 20, so you'd expect the bicarb to go up by how much? 3, right, and it did. It went from 34 to 37. If you just saw these numbers, you might say, could this be acute respiratory acidosis by itself, or chronic respiratory acidosis by itself? So if this cannot be acute respiratory acidosis, obviously, because the PCO2 has gone up about 30. And that means the bicarbonate should go up around 4.5, and it's gone up a lot more. Could this be chronic respiratory acidosis? The PCO2's gone up 27. What should the bicarbonate go up by?
Around like 8 possibly.
Yeah.
Or 8 or 10.
No.
For each.
For each 10, it goes up 3.3.
Yeah. Explained.
So it
Yeah, around
could
9,
round up.
10.
should be around 9. So it can't be 37. Right. 25 plus 9 is 34. So it's gone up too much just for chronic. So you would go through that also when you see these numbers, and they would tell you also there must be a mixed disorder. It can't be just simply chronic respiratory acidosis, although it's close.
When you, for example, you see this patient in the hospital with the second blood cast, what do you call this, like primary respiratory acidosis with
We never use the word primary or secondary when you're using
just
when you're using the term respiratory acidosis. You never use the word primary or secondary.
but that,
It's all- whenever you-
should we write like just like respiratory acidosis
Yeah.
plus
Yeah.
this plus
You would write here.
Okay.
You would write metabolic alkalosis plus acute respiratory acidosis. That's the diagnosis. We never use the word primary or secondary respiratory acid-base disorders because we never call the compensation in metabolic disorders a secondary respiratory acidosis or alkalosis. And because we don't use the word secondary, we never need to use the word primary. Whenever you say respiratory acid-base disorder, you're implying that it is an event by itself. patient. Forty-year-old male who's comatose.
Acutely?
Acutely. Previously, this person had normal blood gases.
That's what you're doing.
Yeah, yeah. That's right, right there. Oh, that's okay. This is the gravity of 10
There's a verification.
Yeah.
So we gotta,
Is that the spec graph 1.013?
Mm-hmm.
This is breath and fruity odor.
Why do you ask?
Just curious.
He has
I
like
check all my
osmolar
patients.
gap of 73, so
Say again?
he has osmolar gap of 73.
Right, what's calculated?
Calculated
Serum
osmolality,
osmolality, yeah.
it's 282.
Hmm?
282?
282.
Yeah.
Right, so he has an osmolar gap. So what,
So it's an anion
well,
gap.
yeah, what's going on with the acid base?
So it's an anion gap.
Got
metabolic
metabolic
acidosis.
acidosis
Anything else?
with superimposed respiratory acidosis. Yeah, because no compensation.
There might be a, depending on what his baseline total CO2 was, he also
This is
may
a
have a little
little
bit.
bit.
He may also have a little bit of metabolic alkalosis, maybe.
Yeah, I mean, assuming this was 25, this is down 15, and the PCO2 is only down by 10.
Yeah.
Assuming he had normal numbers before, so he has a respiratory acidosis in addition. And that could be going along with the coma. Okay, so what do you think is going on here clinically?
So he ingested something, but we don't know.
Right, so what things do you think of when you have an anion gap, metabolic acidosis, and an elevated osmolar gap?
Methanol.
Methanol.
Okay, so ethylene glycol. Any other glycols? You shouldn't just think of ethylene glycol, there's also diethylene glycol. And there's propylene glycol.
Glycol, right?
One of those doesn't cause the,
Isopropyl.
oh, isopropyl doesn't, okay.
Well, there are things that elevate the osmolar gap that don't cause a metabolic acidosis. What are they?
That's what I was trying to think of.
Isopropyl?
Yeah, isopropanol. What else? Ethanol also. Mannitol and glycine people talk about. But basically all the alcohols, other alcohols too. But if you have a metabolic acidosis, you know that what you ingested must have been converted to an acid. Something had to be created with a proton. So if it's methanol, what's the acid that's made that does this?
Formic acid.
Yeah, formic acid. And if it's ethylene glycol,
Propionate?
It's glyoxylic acid and oxalic acid. What's one of the clues? You have ethylene glycol ingestion when you look at the urine. Yeah, you have oxalate crystals.
Crystals.
So now you have oxalic acid, the proton is creating the metabolic acidosis, and the oxalate can crystallize and give you crystals in the urine. What's the other clue that you have ethylene glycol intoxication? What's ethylene glycol look like when you buy it?
Oh, yeah,
Is it clear?
Oh, yeah, you can do the woods lamp, right?
Yeah, it's green. It's green because they want you to buy it, so they put fluorescein in it,
Yeah.
and so it fluoresces. So if you shine around 400 nanometer light on it, you'll excite the fluorescein, and the urine will look green. Same as getting a fluorescein angiogram, the same compound. And this patient actually had methanol intoxication. His discs were hyperemic.
The spec graph, what does that tell us in this setting? Does it help us differentiate at all?
No,
Why did you give it to us?
just to throw you off.
Nice.
Actually, I was gonna look at it. Yeah, okay. Without you guys.
There's a 70-year-old diabetic with chronic bronchitis.
Is it the right?
Was treated with an ACE inhibitor because of CHF, and then developed chest pain. He came to the ER with a blood pressure of 80/60, pulse 125, respiratory rate 35, crackles in the chest, and 3+ edema. And these are the numbers.
It says ketones
Negative.
negative.
So what's going on here? PCO2 is 60 and the bicarb's 20.
He has both respiratory acidosis and metabolic acidosis.
Right.
Yeah.
He has gap, yeah, Anion Gap of 24.
So what else must he have?
Well, it covers the metabolic alkalosis.
Well, that's the question, does he? If the PCO2 was 60, let's say his PCO2 was 60 chronically, he has chronic bronchitis, what would the bicarbonate be?
Oh,
So
it's
about 20, will be like around 31,
Yeah, 31.
right?
So the bicarbonate fell by 10,
Mhm.
10 or 11. What was his anion gap?
24.
24.
So the changes are roughly the same, assuming his
As long as
anion gap's
pure-
13, 14. We don't know what his normal anion gap is, but assuming it's 13 or 14, it changed by 10, which is exactly what his bicarbonate changed by.
So that
So
the
it-
gap is 1?
Right, so you wouldn't hypothesize metabolic alkalosis here.
Yeah.
I mean, you don't know for sure because you don't know his normal anion gap is, but
Yeah.
assuming it's 13, 14, then the simplest thing is that this guy had a chronic respiratory acidosis and then developed metabolic acidosis from the worsening heart failure. His lactate came back at 10. So this is a lactic acidosis on top of a chronic respiratory acidosis. Now what about his PO2 of 50? Is this due to hypoventilation or does he have a VQ abnormality in addition?
Is it a venous gas?
This is arterial. What's his AA gradient?
What's his FiO2? Is he?
He's on room air. This is when he came into the ER. So how do you calculate the alveolar PO2 on room air? What's the equation?
The alveolar gas equation. I'd have to look
Right,
it
you
up.
should always do that when you get your blood gases. Every blood gas you should always check if your patient has hypoxia from hypoventilation or from a VQ abnormality. So it's 150 minus 5/4 of your PCO2. So the PCO2 here is 60. So what's 5/4 of 60?
75.
Yeah, 75 is the PO2 in his alveoli. So what should the PO2 be in his blood if you had normal lungs and no VQ abnormality? What would the PO2 be in your blood if your alveolar PCO2 was 75?
75.
No, it's not the same.
It's like maybe 5.
There's always a
yes.
difference of 10.
Or 10.
It's called the A. You ever hear of the AA gradient?
Yeah.
Yeah.
It's the AA gradient is the normal difference between the alveolar and arterial PO2s. So if the alveolar is 75, the highest this could be would be 65. So it's a little bit worse, but it's not horribly worse. So it's suggested that his hypoxia is mainly due to the fact that he's hypoventilating and the PCO2 in his alveoli is going up and the PO2 then is falling in the alveoli. You're not going to expect to see anything on chest x-ray as a cause of his hypoxia. So remember, chronic bronchitic is hypoxic because of a decreased alveolar PO2.
Yeah, it's interesting because clinically, I'd be very surprised if that chest X-ray came back normal with gross volume overload
I would agree.
and
But it
CHF.
suggests that he doesn't have a lot going on in the lung parenchyma, otherwise you would think his PO2 would be, oh, I'm sorry, no, I'm giving you the wrong answers. PO2 is 50. So his A gradient here is
15.
no, it's 75 minus 50, it's 25. So I'm telling you wrong. He has
No,
a
the
bit-
alveolar was 75 and blood we decided
it's-
65.
No, his blood is 50.
A maximum
I was looking at
65.
the wrong number. So his A gradient here is 25.
Oh, yeah.
So he has a big A gradient, so you would expect to see something on the chest x-ray here. Because if it was just hypoventilation, his PO2 would be 65. If it was just a chronic bronchitis, and the fact that it fell another 15 due to something that wasn't due to hypoventilation. So remember the two extremes, chronic bronchitics have a decreased alveolar PO2, and that's why they're hypoxic, whereas an emphysematous patient has actually an increased alveolar PO2. And yet they're hypoxic because they have a big A gradient. They have parenchymal lung disease with a VQ abnormality. So remember that an emphysematous patient, what acid-base disorder does an emphysematous patient have?
Also chronic respiratory acidosis.
Alkalosis. They're hyperventilating.
Emphysema? They just end up being
The
COPD.
the two extremes are chronic bronchitis and emphysema. You ever hear of the blue bloaters and pink puffers?
Right.
They're pink, right? Their PCO2s are decreased, and they have an increased alveolar PO2. Remember, anyone with chronic respiratory alkalosis or respiratory alkalosis has a higher than normal PO2 in their alveoli, because the PCO2 drops and the alveolar PO2 goes up. So the emphysematous patient has a greater than normal alveolar PO2 and they're still hypoxic. So they have a big VQ abnormality, whereas the chronic bronchitic is hypoxic because their alveolar PO2 is too low. But they have a normal AA gradient. These people have an increased AA gradient. So just remember that when you have a respiratory acid-base disorder, it affects your alveolar PO2. And you should always check someone's AA gradient and the reason why they're hypoxic. This is a 43-year-old male admitted with altered consciousness, nausea, and vomiting. So the PCO2 is 35 and the bicarbonate is 14.
Do we have baseline?
No.
There's definitely metabolic acidosis with,
Why do you say?
because of low bicarbonate and increased anion gap.
What's the anion gap?
21.
So there's an anion gap, metabolic acidosis, and what else?
Respiratory acidosis.
Right, because the PCO2 should be around 30. So it's 35, it's above what you'd predict. So there's a respiratory acidosis in addition. This person took ethylene glycol.
There's no baseline abnormality, there's probably also metabolic alkalosis.
In this patient?
Yeah,
Yeah, there could be.
because if you add, I know we don't add the anion gaps to
Right.
bicarb, but if we did it, for instance,
Right.
it would end up
No,
being
you
36.
can't. I mean, on paper, you would say there should be metabolic alkalosis too. It's a 55-year-old patient with altered mental status.
Salicylate intoxication?
This is, yeah. It's very good. Tell me what the acid-base disorders are.
Respiratory acidosis for sure. This is metabolic acidosis.
Yeah, metabolic acidosis, respiratory alkalosis. Anything else?
Probably metabolic alkalosis.
Right, why do you say that?
Again, because the gap's 27 and the bicarb now is 16.
Right. Yeah, so this person has 3 acid-base disorders. And remember that the compensation that you'd expect is basically a net result of whatever the bicarb happens to be, which is the net of the metabolic acidosis and alkalosis, are leaving it at 15. But you use the same rule as you would for the simple metabolic acidosis, right? Because it's below normality. So just remember here that this bicarbonate of 15 is a net result of the metabolic acidosis and the alkalosis, and the two together have left a person with this bicarbonate. So the question is, what should the PCO2 be? You go by the 1-to-1 rule, even though the bicarbonate is not just due to the metabolic acidosis. It's a little confusing. Yeah, so this patient had salicylate intoxication and also was vomiting, and also has the respiratory alkalosis from the salicylate intoxication. In the last few minutes, I just want to go over this concept of what's called Eucapnic Bicarbonate. So the idea of the Eucapnic Bicarbonate is when you have a metabolic acidosis, let's say your bicarbonate is 25 and you drop it to 15. The Eucapnic Bicarbonate is the bicarbonate had the PCO2 state at 40, because that's felt to be the true metabolic component. And the reason for that is it was shown about 20-25 years ago, which people totally ignore, that the compensation that you get in metabolic acidosis actually makes the bicarbonate fall further. So the bicarbonate that you end up with in metabolic acidosis is not just a result, let's say it's lactic acidosis. The bicarbonate that you get from the lactate alone, the lactic acid, would be the bicarbonate that you have when your PCO2, if your PCO2 could stay at 40. But once you allow the compensation to occur, people found the bicarbonate falls further, independent of the acid load. And so the thought was that when you say the person has a compensated metabolic acidosis, you always essentially have a mixed disorder when you think about it. Because the bicarbonate that you see here is not due just to the acid load. It fell further because, as it would in respiratory alkalosis, it fell further from the fall in the PCO2. It makes the bicarbonate fall an additional amount. And so it turns out that when they did the math, if the bicarbonate was less than 18 to start, the compensation actually made everything worse from the further fall in the bicarbonate. So this brings up the thought, do you ever have a pure disorder? Because the same thing likely occurs in metabolic alkalosis too. The increase in the PCO2 will then make the bicarbonate go up a little bit just from that, in addition to the metabolic alkalosis. So it brings up the question which no one has ever addressed. Do you ever actually have a pure disorder? And the answer probably is no. So the next time you see someone who you say has a metabolic acidosis that's compensated, remember that the bicarbonate that you're seeing is not just due to the metabolic component, but it's due to the fact that the bicarbonate fell further from the drop in the PCO2. The only time you have the pure metabolic component is if when the PCO2 didn't change. But then you wouldn't call that pure metabolic acidosis, which you probably should call it. You would call that metabolic acidosis with respiratory acidosis. So from a diagnostic point of view, you're saying the PCO2 should have fallen, and that's why I'm calling it a respiratory acidosis. But from quantitating the effect of the acidosis on the bicarbonate, it would be best if the PCO2 never changed. So, and that's sort of the concept. If you look at, sometimes on the slips they'll have base excess. So the idea behind all that is that everything is measured with the PCO2 kept at 40, and that gives you the pure metabolic component. So it's called Eucapnic Bicarbonate. And just remember that the compensation itself makes the bicarbonate change in addition, which brings up this problem diagnostically as to whether you ever have a pure disorder. You really don't. So this change of 1-to-1 is actually the net change of the bicarbonate having fallen further from the hyperventilation. The other problem with these rules is that we assume they're independent of each other. So the assumption is if you have a chronic respiratory alkalosis, or let's say chronic respiratory acidosis, and now you get an acute respiratory acidosis, that the acute respiratory acidosis rule applies. And that is an assumption and has also been shown not to be true, at least in dogs. So if you have chronic respiratory acid-base disorders and you develop acute respiratory acid-base disorders, you don't follow these rules. And unfortunately, it depends on what the steady state bicarbonate was before it happened. So that's another problem with the mixed acid-base disorder diagnoses. We implicitly assume these rules apply when you have more than one disturbance. And when it's been looked at least in dogs with the chronic respiratory acid-base disorders, the rules don't apply. At least if you develop an acute respiratory acid-base disorder on top of a chronic one, you don't have this 1.5 to 10 rule. It's different, and it varies for each level of bicarbonate, which makes it even more complicated, so you can't even predict. Well, you could predict in your patient. It hasn't been shown to be true in humans, but it probably is. So that's just another assumption here, and what we've been doing all day, that these rules apply when things are together. We don't know that for sure. We don't know if you have a chronic respiratory acidosis, whether you would have 1-to-1. Well, you wouldn't have 1-to-1 because you wouldn't compensate. So that's not a valid assumption. But we don't know that the acute respiratory acid-base disorder rules would apply. If you have, for instance, a metabolic acidosis, and now you develop an acute respiratory acidosis, we're assuming it's 1.5 to 10, but no one has ever shown that that's true. It may not be. So these kind of things are sort of a subtle problem with what we analyze. And I think I'll stop there. Anybody have any questions at all? You guys all seem to know it.
No, so just basically when they have chronic respiratory acidosis and they come with acute on chronic,
Right.
It's like we can't apply this rules.
Well, the assumption is you can, but in the dogs it's been shown that the rules are changing.
Okay.
Skip blood gases on all your patients
So
routinely.
you can apply the rule and you can write down something, but in your heart you have to know that you may be off.
You may be wrong.
You may be wrong. But Medea showed that in dogs. He created chronic acid-base, respiratory acid-base disorders and then created acute. And he clearly showed that you get a different rule depending on what bicarbonate you start at. So it was nice to see, but it was very disconcerting because that means how do you apply it to the real world? But all the time we're assuming the rules are applying when they're together. Otherwise we couldn't write anything on the chart.
So it's just a coarse rule of thumb to tell you that this isn't right. If all of this and then
Okay, I think I'll stop there.
you create a metabolic alkalosis, there must have been metabolic alkalosis.